All right. All right, we're going to start. Everyone, thanks. All right, welcome to History in the Round. Okay. As you now know by now, certainly I'm Baron Lerner, president of the American Association for the History of Medicine. I do note that I wish that people had been drinking wine before my Garrison talk, and it would have probably gone a lot better. Okay. I wanted to thank the University of Kansas Medical Center for making this beautiful medical education venue available to us and for providing technical support so that we can bring tonight's lecture not only here, but to those unable to be with us in person. As a host of this meeting, KU Medical Center wishes to acknowledge that they reside on the traditional homelands of several tribal nations. Please refer to the program for a full statement. Okay, the Garrison Lecture, one of the marquee events of the annual meeting of the American Association for the History of Medicine, is named for the association's first president, Fielding Hudson Garrison. Each year, a committee selects a Garrison lecture for the succeeding year from a group of distinguished scholars who have made contributions to the history of medicine, science, or learning. The Garrison Lecture, held since 1940, features original and previously unpublished research. Now I get to the fun part, introducing our distinguished scholar for the evening, and it's Dr. Johanna Schoen. She told me, please be irreverent. I said, okay, but I also have to tell people why you actually were chosen. So I'll do a little of both. Johanna Schoen is professor of history at Rutgers University, New Brunswick. She attended the University of Hamburg and received her master's and PhD degrees in history from the University of North Carolina. And she's author of two tremendous books I think many of us have read, Choice and Coercion, Birth Control, Sterilization, and Abortion. Birth Control, Sterilization, and Abortion in Public Health and Welfare in the 20th Century, and Abortion After Roe. And her current research, which this talk will highlight, is on an upcoming book, a ways away, that is currently entitled Life and Death in the Nursery, which is on the history of neonatal intensive care units. And Johanna received a 3-year research grant from the NIH and NLM to work on this. In many of her other activities, I'll just mention one since I know it well. She serves as a volunteer at Memorial Sloan Kettering Cancer Center, where she is emeritus co-chair of the Patient and Family Advisory Council and has worked extensively in facilitating discussions between patients and families dealing with cancer and their clinicians in a very helpful way. I'll also remind you that I said in the newsletter that Johanna is probably everyone's favorite AAHM member, and I think that's true. And also that now we have an official fund committee, but before that she was the fund committee. The title of Dr. Schoen's talk today is Glasnost and Perestroika in the NICU, Clinical Care and Patient Activism, Parent Activism in the History of Neonatal Intensive Care. Johanna. You going to do this or not?
Thank you so much for coming. I was thinking, given the setup, that I could just help you solve the NICU thing in group work. So if you could each take 10 minutes and then we'll report back, or we could do this lecture. Before I start, I have no disclosures. I want to thank Baron for the lovely introduction and Jody and Chris for all the work getting everything ready and helping me with all the technical and organizational stuff. Naomi for her fashion advice, very important. And my wife, Bev, for being incredibly patient with my obsession with neonatal intensive care units. And I also wanted to do a shout out to 2 archives and collections that are not even officially visible in the catalog, but that you will want to go to and you will want to send your graduate students to. The first one at UCSF, the papers of Helen Harrison and Polina Ilyeva was the one who attracted them, and they're unprocessed, but there is a folder. No, there isn't, but I am creating a detailed outline of folders. And the paper today is going to be based on it, so you will see what's in there. It's really remarkable. And then the second one I actually visited last week here in the archives, and you should talk to Alex about them. They're the papers of a pediatrician who created the moral ethical framework, clinical ethical framework for pediatrics and death and dying in pediatrics. And they're the papers of William Bartholomew. They're really fantastic. So every parent, whether they admit it or not, and certainly every historian of medicine knows, thanks to our colleagues, that the birthing process is not only the beginning of life, but is also stalked by morbidity and mortality. To understand this in more recent history, I am now working, as Baron explained, on a book-length project on the history of neonatal intensive care units, tentatively titled Life and Death in the Nursery. It will analyze the emergence of a new subspecialty, neonatology, and the medical technologies employed by neonatologists from the 1960s to the present, centering the experiences of clinicians and parents who met in the NICU. So today I will talk about medical ethics debates that, starting in the late 1970s, emerged with the growth of the advocacy movement of NICU parents. Before I begin, I would like to note that some of the language I will be using is today considered offensive or at least politically incorrect, but for the sake of historical accuracy, I have stuck with the terminologies used at the time. I had a word of caution that you should have drunk before the talk, but you did, so we're all good, as did I. To understand the parent neonatology relationship in our recent history, I start on the 27th of June in 1992, when a group of parents and neonatologists, nurses, and social workers met in Burlington, Vermont to discuss the state of neonatology. Over the course of 2 days, they deliberated on a list of 10 principles that parents whose children had been patients in neonatal intensive care units had developed to address concerns with the medical care their infants had received. Parents' complaints were wide-ranging. They accused neonatologists of disenfranchising and of overruling them if the neonatologists disagreed with parents' wishes regarding the medical treatments premature infants should and should not receive. They charged neonatologists with trying to manipulate parents by offering vague or outright deceptive information when discussing infants' prognosis, withholding information about serious medical problems babies developed in the course of their NICU stay, and concealing the fact that many of the treatments were experimental in nature. And they accused neonatologists with child abuse when clinicians failed to administer pain control during routine medical procedures, as well as during major surgeries. The Burlington Conference was the brainchild of NICU parent turned health advocate Helen Harrison and neonatologist Gerald Lucy. Harrison had earned a degree in Slavic languages from UC Berkeley and worked as a Russian to English translator and as a medical and laboratory technician with the Berkeley Community Health Project when she gave birth to her son Edward in 1975. 3 months premature and suffering from listeriosis, a serious bacterial infection, Edward was not expected to live. When physicians took him off the respirator to allow him to die, however, Edward defied all expectations and continued to breathe. At that point, the NICU staff jumped into action and vigorously supported Edward, who survived with multiple disabilities, including hydrocephalus, a serious neurological disorder caused by the abnormal buildup of spinal fluid in the brain, and severe intellectual disabilities. While Harrison initially had a positive view of the NICU, this changed in the late 1970s and early 1980s when she began to interview parents about their experience with neonatal intensive care units to write a guidebook for parents who experienced the birth of a critically ill premature infant. In retrospect, Harrison noted, I see many ways my interest in Russia helped prepare me for the NICU. It gave me familiarity with totalitarian regimes, pain and suffering, mystifying languages, big lies, and the need for Glasnost and Perestroika. In 1983, she published the Premature Baby book and became one of the founders of Parent Care, an international support organization for parents of high-risk infants. Garrison met Lucy in the mid-1980s when she sent him a letter to the editor for publication in the journal Pediatrics, expressing concerns about the aggressive treatment of very low birth weight infants. Then chief editor of the journal, Lucy took note. Garrison began to forward him letters she had received from other NICU parents. Ultimately, their joint attempt to offer concerned parents a forum to articulate their criticism led to the organization of the Burlington Conference. Gerald Lucy, a member of the first generation of neonatologists in the US, graduated in 1952 from NYU's College of Medicine. Over the following years, he interned at Bellevue Hospital's Children's Medical Services and did his residency at Babies Hospital, part of Columbia Presbyterian Medical Center in New York City. There, he trained with Bill Silverman, one of the founders of neonatology and an early voice for ethical care in the field. After a research fellowship at Boston Children's Hospital and Harvard Medical School, Lucy joined the University of Vermont College of Medicine in 1956. He spent his career advocating for the practice of evidence-based medicine in neonatology, and as chief editor of Pediatrics, offered NICU parents a forum to voice their thoughts. Starting in the post-World War II years, the country began to direct its attention and considerable resources to medical issues considered of national importance, among them the high infant mortality rate. Americans approached the care of preemies with an aggressive optimism that reflected the national faith in science and technology and the concern with needing more children. As clinicians began to use new and untested treatments and medical technologies to try to keep premature babies alive, however, results were often catastrophic. In the 1940s and 50s, it became increasingly fashionable, for instance, to give large amounts of oxygen to preemies who, as a result of their immature lungs, had developed respiratory distress syndrome. This had led to an epidemic of infant blindness, including for Stevie Wonder, who was born in 1950, 6 weeks premature. It wasn't until 1954 that the result of a national cooperative study among 18 hospitals indicated that the cause of blindness was too much oxygen. Clinicians knew how to take care of premature babies who were relatively well, but didn't know how to treat severely ill newborns. Assessing the state of newborn care in the late 1950s, pediatricians realized that they were failing critically ill newborns and began to look towards the establishment of intensive care nurseries to care for premature and extremely sick babies. It is difficult to overstate the structural hurdles clinicians had to overcome to establish centralized neonatal intensive care units. Intensive care across the country was isolated and fragmented, frequently consisting of a series of tiny sequestered cubicles or an isolated area filled with bulky electronic equipment. In addition, hospitals were subject to waves of staph infections, and state laws required that patients be isolated within their respective wards. A careful review of the literature led neonatologist Louis Gluck, also trained by Bill Silverman, and his colleagues to realize that the infections were not, as assumed, airborne, but spread because people a century after Semmelweis failed to wash their hands and picked their noses. In 1959, Gluck set up a controlled study testing his theories of infection. He and his colleagues began to wash 1 out of every 3 babies in the delivery room with a disinfectant, thereby virtually eradicating staphylococcal colonization in the newborn. The following year, Gluck convinced administrators at Yale to open the first neonatal intensive care unit in the country. Carefully planned to incorporate the latest design, the new Yale New Haven Special Care Nursery was a marvel and model of modern medicine, offering sick infants and their parents a dazzling array of new technologies in one space. It featured 1 large and 3 smaller rooms built around a central nursing station. To increase efficiency, the design team placed the 40 isolate only 20 feet apart from each other and installed all equipment for each isolate in the ceiling above. Flexible tubes for oxygen, compressed air, suction, and multiple electrical outlets hung down from the ceiling, allowing nurses and physicians to instantaneously attach respirators, monitoring devices, and infusion pumps to the infants below. In addition, clinicians had access to a variety of standard and cardiopulmonary monitoring and resuscitation instruments, including a volume-controlled respirator, a portable unit to determine blood gases, cardiac monitors, apnea alarms, as well as an open-air radiant heater crib, which permitted clinicians to perform procedures without worrying that infants would develop hypothermia. Windowless, the unit was located in the middle of the building. The overhead lighting and the constant hum and beeping of the medical equipment made the space loud, noisy, and bright. It reminded me of the movie Coma, one of the nurses remembered. The bodies were all suspended and they were maintained by machines. This is a great reason to do oral histories, so people tell you these things. The establishment of neonatal intensive care units, journalist Jeff Lyon observed in Playing God in the Nursery, was inspired by parallel developments in adult medicine. The first adult intensive care unit was established in 1959 at Los Angeles County General Hospital. It was followed in 1962 by the first coronary care unit founded at Bethany Hospital in Kansas City. The Yale New Haven Special Care Nursery emerged alongside NICUs in other medical centers in the US. In Nashville, neonatologist Mildred Stahlman established a neonatal intensive care unit at the Vanderbilt University Medical Center in 1961. Funding from the National Institute for Health to study respiratory distress syndrome allowed Stahlman to equip the new facility. In other medical centers, too, physicians began to experiment with the idea of neonatal intensive care units. Hospitals in London, Toronto, Montreal, Stanford, Boston, the University of Pennsylvania, the University of California at San Francisco, and Johns Hopkins University all established NICUs in the early 1960s. With the establishment of NICUs, the treatment of premature and critically ill newborns changed from a philosophy of handling the infants as little as possible to one of aggressive treatment. The establishment of clinical centers devoted to the care of premature and sick infants increased the number of infant patients, as well as the clinical problems with which infants presented. But the ability to now treat severely ill infants for whom treatment had not been available earlier also led to disagreements between physicians or between physicians and parents over appropriate treatment options. This was especially the case in situations where clinicians and parents were unexpectedly confronted with a child with congenital anomalies, such as infants born with trisomy 21, Down syndrome, with duodenal atresia, an intestinal obstruction that prevents food and fluids to pass from the stomach to the intestine, or infants born with myelomeningocele, the most common and most severe form of spina bifida, a congenital nervous system defect. The establishment of NICUs and special care nurseries allowed clinicians for the first time to systematically address the surgical needs of these infants, and in the course of the next 2 decades, changed the clinical understanding of what could and should be done for them. Since a third of infants with duodenal atresia have trisomy 21, the classic textbook, The Surgery of Infancy and Childhood, had advised surgeons in the 1950s to carefully evaluate all infants with duodenal atresia and to forego corrective surgery if infants showed signs of trisomy 21. Similarly, before the 1950s, the prognosis for infants with myelomeningocele, which involves varying degrees of leg paralysis and bladder and bowel impairment, was poor. Approximately 80% of children with MMC have hydrocephalus, which can result in cognitive impairment and blindness. Most died in the first few months of life of meningitis or as a result of hydrocephalus. Because of the complex medical needs of these infants, as well as the social stigma and isolation of giving birth to a child with severe disability, children with MMC and trisomy 21 were, until the 1950s, frequently raised in institutions. Indeed, considering the outcomes for these infants extremely poor, clinicians regularly advised parents that infants with trisomy 21 and duodenal atresia, as well as infants with myelomeningocele, be left to die. But three things changed in the 1960s. First, the growth of clinical genetics in the 1950s and 60s led to an understanding of genetic diseases, and in the 1970s and 80s, screening tools, including the use of ultrasound, amniocentesis, and eventually chorionic villi sampling, allowed for the detection of these conditions during pregnancy, and with the legalization of abortion and expansion of abortion procedures, gave women the opportunity to end the pregnancy in case of a positive test result. Second, a number of exposés in the 1960s highlighted terrible conditions in mental institutions and residential schools, leading activists to lobby for deinstitutionalization. After the Kennedy administration in 1963 elevated mental retardation to a federal health policy issue, the federal government adopted an approach to reduce institutional populations and offer community support. Parents, too, began to voice concerns about institutionalization, and some began to establish advocacy groups that moved children with disabilities into the mainstream. Third, advances in therapies and refinement of surgical techniques contributed to the survival and higher functioning of infants with spina bifida and other health problems. By the early 1960s, the development of antibiotics to treat meningitis and of shunts to alleviate hydrocephalus allowed physicians to aggressively treat infants with MMC. And as the 1960s progressed, clinicians' attitudes for infants with trisomy 21 also began to shift. By the early 1960s, the surgical correction of duodenal atresia was well established. Moreover, major changes in the clinical care of premature infants in the 1960s meant that clinicians could now keep their patients alive. The provision of assisted ventilation for continuous respiratory support in the mid-1960s and the development and administration of surfactant to premature infants to treat respiratory distress syndrome revolutionized the field of neonatal medicine, while the introduction of IV feeding and the development of micro-infusion pumps allowed for the feeding of extremely preterm infants, and by the end of the decade, high-caloric IV preparations were better able to meet their nutritional needs. These changes notwithstanding, many parents continue to be wary of raising a child with severe disabilities. As Leslie Reagan has illustrated, the rubella epidemic and the thalidomide scare in the 1960s heightened Americans' concern about bringing home an infant with a disability. Faced with caring for a severely disabled and or intellectually impaired child, families confronted significant caregiving burdens and expenses. They struggled with social shame and isolation at a time when raising a disabled child at home was still an intensely private experience. As one neonatologist remembered, parents dreaded having retarded children. When in 1963, pediatricians at Johns Hopkins University encountered an infant born prematurely with trisomy 21 and duodenal atresia, a debate about the treatment of the infant ensued. Worried about the impact that a child with severe disabilities would have on their families, including the 3- and 5-year-old siblings at home, the parents refused to sign the permission for the surgery that would have corrected the duodenal atresia. The infant died 6 days later. By the early 1970s, medical files at Johns Hopkins University Hospital suggest that the 1963 infant had not been alone. Other infants born with trisomy 21 and duodenal atresia too had been left untreated and had died. Indeed, it is likely that this happened in hospitals around the country. When in 1971, Robert E. Cook pediatrician-in-chief and chairman of the Department of Pediatrics learned of another infant with trisomy 21 and duodenal atresia whose parents had decided against surgery, he tried unsuccessfully to intervene. The infant died after 13 days. Dissatisfied with his faculty, some of whom had supported the parents' decision, Cook turned to the Joseph P. Kennedy Jr. Foundation, which was preparing an international symposium on human rights retardation and research, and suggested the creation of a brief documentary dramatizing the 1963 and 1971 cases to screen at the opening of the symposium. The resulting film, Who Shall Survive, one of the choices on our conscience, premiered in October of 1971 against the backdrop of debates over the legalization of abortion, changing protocols regarding brain death, and the beginning of bioethics. Over 9 minutes and 15 seconds, it traces the delivery of baby Doe, his diagnosis with trisomy 21 and duodenal atresia, the parent's decision not to consent to surgery, the sign on his crib indicating that he should receive nothing by mouth, and the wait until his death in the documentary 15 days later. The film highlighted the moral distress of the staff as the baby slowly starved to death. One could not come away from watching the film without the impression that what had happened here was wrong. More than any other case up to that time, Who Shall Survive brought the issue of end-of-life decisions involving infants with disabilities out of the back rooms of the hospital and to international attention. Over the course of the 1970s, clinicians debated the ethics of non-treatment and the clinical details surrounding these decisions. In a 1973 article published in the New England Journal of Medicine, 2 pediatricians at the Yale New Haven Special Care Nursery articulated their concern with the increasing number of severely disabled infants who now survived due to advancements in neonatology. In hospitals with infant intensive care units, they noted, neonatal mortality rates had fallen by half over the past decade compared to hospitals without such units. But while some survivors of these units were healthy, others continued to suffer. Severely handicapped by a myriad of congenital malformation that in previous times would have resulted in early death, the authors wrote, the new treatment options raised increasing concern about the quality of life for these severely impaired survivors and their families. Some clinicians bemoaned the emotional suffering and chronic grief that attended the birth and survival of what was labeled a deformed, retarded child and urged careful evaluation to identify hopeless, burdensome cases before initiating expensive and life-prolonging treatment. Quote, the emotional and physical pain that we cause child patients to suffer, they concluded, must be justifiable in terms of some reasonable hope for a future happy social adjustment, end quote. But clinicians lacked a unified understanding of the meaning of future happy social adjustment, while some sought to ensure that infants would be able to become productive citizens, others warned against such utilitarian views. The experience of Peggy and Robert Stinson well illustrates the suffering and chronic grief that could accompany neonatal care by the 1970s. On October 17, 1976, Peggy Stinson gave birth to their son Andrew at a community hospital in Bethlehem, Pennsylvania. At 800 grams and gestational age of 24.5 weeks, Andrew was not expected to survive. Peggy and Robert asked the medical staff at community hospital that no heroic efforts be made to extend his life. Against their wishes, hospital staff transferred Andrew a week after his birth to the NICU at Children's Hospital in Philadelphia, a tertiary care hospital where he was placed on a respirator. Over the next 5 months, and following on the heels of the Karen Quinlan case, he became, in the words of his parents, hopelessly entrapped in an intensive care unit where the machinery was more sophisticated than the code of law and ethics governing its use. He remained dependent on the respirator until he was finally allowed to die 5 months later. As a result of the treatments he received to trying to keep him alive, Andrew developed a range of complications. Placed on a respirator, he developed bronchopulmonary dysplasia, neonatal chronic lung disease, as well as retrolental fibroplasia, an eye disease frequently leading to blindness. The chronic lung problems in turn led to a slowing of Andrew's heart rate and a lack of oxygen in his blood. Unable to meet his nutritional needs, in particular his needs of minerals, he suffered from multiple bone fractures. As Andrew's lungs began irreparably diseased, he developed high blood pressure and began to have seizures. When on June 10th, Andrew dislodged the tube connecting him to the respirator, CHOP's physicians decided not to reconnect him. He finally died on June 14th, 1977. As his parents sarcastically noted, he was in effect saved by the respirator to die 5 long, painful, and expensive months later of the respirator's side effects. Devastated and furious, Peggy and Robert Stinson wrote a letter to CHOP's administrators and personnel, sharply criticizing the aggressive treatment of Andrew. The story of Andrew's short, cruel, institutionalized life, they warned, is a case study in the limits and excesses of modern medicine. In 1979, they published a book, The Long Dying of Baby Andrew, about the ordeal. In addition, they published an abridged version of their letter to the hospital in Atlantic Monthly, and in 1981 in the Journal of Medical Ethics. Andrew Stinson's case was far from exceptional. Parents across the country found that neonatologists ignored their wishes to allow their severely ill infants to die, instead resorting to coercion, threats, and court orders to treat the infants only to have them die months or even years after gruesome medical ordeals. The Stinsons' complaints were followed a couple years later by similar charges from California couple Sue and John West, who in October 1980 gave birth to their infant son, Brian. Brian was diagnosed with trisomy 21, a missing esophagus, and a heart murmur. The attending physician described how the particular combination of Brian's defects were far more serious than either one would have been alone. His missing esophagus could be surgically reconstructed, but Brian would never be able to swallow normally and would be constantly in danger of choking on his food. Since trisomy 21 was associated with poor muscle tone, this further increased Brian's chances of choking. In addition, stomach acids would back up into his reconstructed esophagus, and since children with trisomy 21 are also overly susceptible to upper respiratory infections, without a properly functioning esophagus to drain normal secretions to the stomach, these fluids could back up, enter the lungs, and cause pneumonia. Finally, physical therapists warned that the reduced mental capacity of children with trisomy 21 might defeat the therapeutic process required to learn how to use the new esophagus, and that Brian's frequent hospitalizations and surgical interventions would mean that an attempt at early intervention and stimulation, so crucial for children with trisomy 21, would be frustrated, indeed might significantly set Brian back. Doubting that the long-range outcome for Brian would be good, the Wests refused to authorize the surgical repair of Brian's esophagus. The decision, John West remembered, quote, was based on love and on the golden rule. Had they been in Brian's place, neither he nor his wife would have wanted to be kept alive. The hospital's doctors and administrators, however, disagreed with the West's refusal to consent to Brian's surgery and asked the state to bring charges under the state's child abuse laws against the Wests. The Wests were charged with willful neglect, and Brian was removed from their custody and placed under the guardianship of the state. As Susan West recalled, we watched helplessly as our baby endured multiple surgeries and a host of chronic, painful maladies. Brian spent the initial months of his life attached to a nasal suction machine and was fed by a hose through a hole in his stomach. Infections became chronic. Reconstructive surgery on the esophagus was performed in 2 stages when he was a little over a year old. The process can only be described as hell for him. The wounds failed to heal properly, stomach acid backed up continuously, causing such pain and irritation that it became necessary to restrain the baby's hands and feet by tying them to the four corners of the crib. His new esophagus was never functional, and he became caught in a perpetual pilgrimage from nursing home to hospital and back again. Shortly after his second birthday, in October of 1982, another infection of unknown origin sent him to the hospital once again. While there, he went into respiratory shock and was placed unconscious on a respirator. When he stabilized, he was severely brain damaged, blind, bleeding internally, experiencing intermittent kidney failure, and had an overwhelming infection throughout his body. On December 21, 1982, at 26 months of age and weighing only 14 pounds, Brian James West finally died. 5 days later, John and Susan West appeared on CBS's 60 Minutes to talk about their experience. Neonatologists' willingness to consider parents' requests against aggressive care declined further in the early 1980s after President Ronald Reagan, prompted by outcries of his right to life constituents, passed so-called baby doe regulations, which threatened hospitals with the loss of their federal funds if they withheld medical treatment or nourishment from handicapped newborns. To facilitate whistleblower reports of alleged violations, the administration established a toll-free 24-hour handicapped infant hotline with the number prominently displayed in delivery rooms in pediatric wards. 2 years later, the regulations were added as an amendment to the Child Abuse and Neglect Prevention and Treatment Act, which made withholding medical treatment a reportable act of neglect and abuse. By 1987, Child Protective Services had received 41 complaints and intervened in 11 cases, affecting a change in treatment decisions, always in favor of treatment, in 10 of these. Just as pro-lifers can stop abortion clinics, one neonatologist lamented, there is a group of people who are just as put out about our willingness to have a dialogue with parents about withdrawing therapy. Baby doe has made it that much harder for us. The regulation not only pressured neonatologists to resuscitate infants, even if the outlook for their survival and quality of life seemed low, passed at the same time as the Reagan administration gag order prohibiting healthcare providers at facilities receiving federal funds to advise patients about abortion. They left couples with no information about the few choices they might have had. And the baby doe regulations further encouraged intimidated healthcare providers to aggressively treat even the sickest infants. By the end of the 1980s, neonatologists routinely treated infants whose chance of survival was low and who were likely to end up with significant disabilities and health problems for years to come. An analysis of 1,765 very low birth weight infants delivered between November 1987 and October 1988 at 7 NICUs illustrates the outcome. Less than a quarter of premature infants born at 23 weeks gestation survived to discharge from the NICU. At 24 weeks gestation, survival rates to NICU discharge climbed to 1/3 of all infants treated, and by 25 weeks, the survival rate reached 54%. Premature infants fared worse the lower their birth weight. Only 1/3 of infants with a birth weight below 750 grams survived to NICU discharge, and only 15% were free of major complications, such as chronic lung disease, necrotizing enterocolitis, and grade 3 or 4 intraventicular hemorrhage. Survival rates reached 2/3 with a birth rate between 751 and 1,000 grams, and 93% of infants born with a birth weight between 1,251 and 1,500 grams. But the analysis also revealed important variation between NICUs, as well as differences in the philosophy of care and definition and prevalence of morbidity. Depending on the NICU, survival rates for infants below 751 grams, for instance, ranged from 20 to 55%. 2 centers provided assisted ventilation to practically every infant, whereas in some of the medical centers, Some extremely immature infants, those below 751 grams, were not treated at all. Emerging alongside patients' rights movement of the 1970s and activism on behalf of HIV/AIDS patients, parents began to protest the condition under which their infants were being treated. When in the mid-1980s, Jill Lawson learned that her premature son, Jeffrey, had been awake throughout major surgery at Children's Hospital National Medical Center in Washington, D.C., the anesthesiologist had paralyzed Jeffrey with Pavulen, a curate drug that left him unable to move but totally conscious. Lawson raised alarm. Together with Helen Harrison, Lawson protested this practice in letters to the editor of Birth. 10 years ago, Harrison wrote in her letter to the editor, our prematurely born son, Edward, was shunted for hydrocephalus while paralyzed with curare. Although he could not move, cry, or react in any way, he could see, hear, and feel as large incisions were cut in his scalp, neck, and abdomen, as a hole was drilled in his skull, as a tube was inserted into the center of his brain, then pushed down under the skin of his neck, chest, and abdomen, and implanted deep in his abdominal cavity. At a 1985 National Conference of Parents of Premature and High-Risk Infants, mothers and fathers discussed a wide array of painful medical procedures that children had been subjected to. Major surgery, chest tube insertion, cut downs, a surgical procedure to gain venous access, all performed without painkillers, gangrene and amputations from infiltrated IVs, bones broken during chest physiotherapy, skin pulled off with adhesive tape, and burns from the monitors. Added to that were the 24-hour-a-day bombardment with bright light and loud noise and numerous iatrogenic afflictions from improperly evaluated therapies. If this were going on in any other setting, one mother explained, it would be called torture. I have long wondered how an infant can differentiate between pain or abuse that is medically necessary and abuse at the hands of an out-of-control parent or caretaker, another noted. It is generally acknowledged that abused infants become emotionally scarred. No one says they will be fine because they can't remember, yet the myth remains that NICU veterans forget. And indeed, parents argued that their children did not forget. We have seen our child grow up obsessed with medical pain, Alfred Harrison told the Burlington audience of parents and neonatologists. The thousands of other painful procedures inflicted on Edward, both in the nursery and later during shunt revisions, heel cord surgery, and other operations, have left an obsession with pain in this retarded child's mind. We can't even take him to the pediatrician for a routine checkup without him literally shaking in fear with sweat popping out on his forehead. It's not that the pain comes and goes and it's forgotten. It's always there in his mind. For many NICU graduates, the NICU was only the beginning of years of medical treatments they had to endure. Infants who had received shunts for hydrocephalus, for instance, could face many surgeries for shunt revisions as they outgrew their shunts or as the shunts became infected. By the time of the Burlington Conference, 16 years of age, Edward had endured 13 surgeries, including 7 in the past 2 years. Many children experienced those procedures as painful and traumatic. As one mother reported about her 8-year-old son, with whom she tried to talk about his shunts, quote, he keeps saying that it's too scary, he doesn't want to hear about it, end quote. And every time she took him to the doctor, he, like Edward Harrison, shook and trembled and took him days to get over it. Given these realities, it is no surprise that families complained of being stripped of their parental rights in the NICU, only to be handed many months later a severely impaired baby whose overwhelming problems were now to be the parents' responsibility. Bob and Sarah Thorson, whose triplets were born in 1987 at 27 weeks gestation, recalled that when their sons were born, it was made clear to us that in no way were we going to be part of the decision-making process for our sons. We were hoping and assuming that we would have some information and ability to help with decision-making regarding the boys, but that was immediately taken away. Neonatologists also intentionally offered misleading information and withheld crucial information about infants' conditions. Wanda Boggs, a Milwaukee mother who gave birth to twins at 24-week gestation, was not told about her son's devastating intraventricular hemorrhage until a week after it occurred, and only learned about it after she and her husband had begun to ask pointed questions. When we asked about the consequences of such a severe bleed, Boggs recalled, we were told that our son might have problems in math later on. Meanwhile, a neurologist was writing in the chart that a likely outcome was a persistent vegetative state. Researchers analyzing the relationship between parents and NICU staff acknowledged that the information parents received often consisted of euphemisms and half-truths. Dr. Carol Rodman, who studied decision-making for infants below 1,000 grams, noted that at resuscitation, treatment planning, and withdrawal of treatment, three crucial junctures of moral decisions, parents were either not invited at all to participate in decision-making or influenced in their choices by misleading information. Of course, treating patients and performing surgeries with no or inadequate information and informed consent was not particular to the NICU setting, but has a long history. As so many of you have illustrated, whether or not patients received medical treatments they actually wanted, were given information, were asked for their consent, and received pain control, for instance, has always been contingent on their position in society. Neonatologists and pediatric surgeons, for their part, often became caught up in the excitement of addressing clinical problems in the present while losing sight of the fact that parents worried about the long-term future. Doctors worried that infants were too fragile to tolerate anesthesia. Others believed that preemies did not feel pain. Some surgeons were unaware that they were operating on an infant without anesthesia. Finally, especially after the passage of the baby doe legislation, the discussion over treatment of severely ill neonates became distorted by pro-life politics. Many neonatologists began to practice defensive medicine. Others tied their support for aggressive treatment to their own pro-life beliefs. Clinicians shied away from an open discussion about the suffering infants might endure as a result of treatment, foreclosing a consideration whether allowing an infant to die might be more humane than attempting or continuing treatment. Instead, they trivialized and oversimplified the medical problems of infants and refused to acknowledge the broad range of functionality and further health complication infants and their families might face in the future. Parents also criticized the lack of long-term outcome studies that left neonatologists unable to predict whether infants would recover relatively normal or spend their lives with severe disabilities. Most follow-up studies of NICU graduates ceased when the child was 2 or 3 years of age. This time period, parents argued, was too brief to predict with some accuracy what the quality of life for premature infants might be. At age 3, we thought our son Edward might be a genius, Alfred Harrison pointed out. He could count to 100, he could read, he could distinguish a trapezoid from an octagon. Many people, including medical and developmental experts, told us this kid is advanced. It wasn't until he was 5 or 6 years old that we knew he was actually severely retarded. And we know from talking to many other parents that some important disabilities don't show up until school age or beyond. If we are going to weigh the pain to gain ratio in this whole process and put these kids and parents through the medical ordeals that can last for years, we ought to have a pretty good idea of what's going on, what it's going to mean in the long term. But following NICU graduates longer, neonatologists argued, was prohibitively expensive, since it was difficult to keep track of families through moves and family changes. In addition, clinicians felt that the rapid therapeutic changes in neonatology would mean that outcome studies would be clinically useless, as they reflected the stage of clinical practice at the time a child had been a NICU patient rather than at the time of the follow-up. Indeed, it was not just long-term outcome studies that were missing in neonatology. Following the pattern of the 1940s and 50s, when clinicians used new and untested treatments and medical technologies to try to keep premature babies alive, Therapeutic interventions in neonatologies continue to be long on experimentation and short on rigorous studies of safety and efficacy. Many methods of treatment have been introduced following reports of their effectiveness on limited numbers of infants, and in many instances without controlled clinical trials, the National Institute for Child Health and Human Development found in 1985. It appears that the practice of neonatal medicine remains in part an art rather than an exact science. The lack of research was a particular point of contention at the Burlington Conference. By 1992, when attendees convened at the University of Vermont, the licensing of surfactant, a chemical compound that supported the breathing of infants with underdeveloped lungs, significantly increased the survival of ever smaller premature babies. Surfactant was responsible for the biggest drop in infant mortality, showing its most significant effect in infants born with a birth weight below 1,000 grams. But parents and some of the neonatologists questioned the cost of trying to save ever smaller infants. As neonatologist Bill Silverman noted, many parents feel that when their marginally viable infant is born, there should be no attempt at active resuscitation. It has now become routine practice, and we have to ask, how did this happen? The modern practice of routine resuscitation versus the older practice of discretionary resuscitation based on parents' wishes has never been compared in a formal trial. The full social and biological consequences of the all-out never say die policy have never been examined. Parents agreed, calling routine resuscitation the beginning of the slippery slope of aggressive treatment and the treatment of tiny infants in the intensive care unit a gigantic experiment. Neonatologists had, throughout their years of practice, studied the outcomes of NICU survivors, articulated similar concerns. In my early years, running the follow-up clinic was a gratifying experience, as most babies had normal catch-up growth, development, and behavior, Raleigh neonatologist James Thallen noted. Of the few handicapped survivors, most had spastic diplegia unassociated with mental retardation, which was amenable to early intervention. 15 years later, the complexity of medical and psychosocial problems has increased. The children are fragile and the families are very stressed, severely stressed. Now his follow-up clinic brought children who suffered from poor growth, whose cerebral palsy was further complicated by visual, auditory, and mental disabilities, and who had chronic lung disease, tracheostomies, and were dependent on oxygen on continuous feeding via infusion pumps. Parents framed the need for accurate information, appropriate pain control, and the ability to influence how aggressive the medical care of their premature infants ought to be as an overriding ethical issue in neonatal care. Given that the benefits of many of the intervention and therapies their infants received were unknown, parents urged neonatologists to inform them about debates in the field and to make research regarding pain control in infants their priority. Helen Harrison implored neonatologists at the Burlington Conference to acknowledge pain control as the ethical issue parents understood it to be. If physicians feel they can't give premature babies safe and effective pain relief for surgery or for severe chronic pain, then the pain these babies suffer becomes an ethical issue that should be specifically discussed with the parents, she noted, and expressed her frustration that after years of advocacy and protest, pain control in the NICU continued to be an issue. And a father urged, if you are going to put a small infant on a ventilator, at least tell the parents there is some controversy out there, that there is a question whether treatment is worthwhile under 1,200 grams or 800 grams or whatever the limit is today. The 10 principles, The 10 principles discussed at the Burlington Conference asked for parents' greater involvement in clinical decision-making and improved neonatal care for the infant patients. Neonatal care, the principles urged, should be family-centered and based on open and honest communication between parents and professionals. Parents should receive all the facts concerning their infant's medical conditions to allow them to participate in truly informed decision-making, including information about uncertainties, as well as information from parents whose children had been in similar medical situations. In any medical situation involving very high mortality and morbidity, great suffering, and/or significant medical controversy, parents should have the right to make decisions regarding aggressive treatment for their infants. But parents also wanted earlier education about the ways a pregnancy might go wrong. Expectant parents, the principals noted, should be offered information about adverse pregnancy outcomes and be given the opportunities to state in advance their treatment preferences if their baby is born extremely prematurely and/or critically ill. The guidelines also implored neonatologists to acknowledge and alleviate the pain of infants, ensure an appropriate environment for babies in the NICU, as well as the safety and efficacy of neonatal treatments. Finally, the principals pushed for greater collaboration between parents and professionals to promote meaningful long-term follow-up for all high-risk NICU survivors and acknowledge that critically ill newborns can be harmed by overtreatment as well as by undertreatment. We must work together, the principals concluded, to insist that our laws and treatment policies be based on compassion, to promote awareness of the needs of NICU survivors with disabilities, to ensure adequate support for them and their families, and to decrease disability through universal prenatal care. While the Burlington Conference was an important step in the crafting of the 10 principles, which Garrison published in a pediatrics article the following year, Garrison noted in the end that the conference was, quote, not all sweetness and light. Significant disagreements remained, both about the importance of pain control for premature babies and about the use of birth weight or similar criteria to define areas in which parents should be able to have a voice in treatment choices. The disputes pitted one group of doctors on the side of parents, while another group remained critical of the principles. Indeed, Garrison reported that one of the neonatologists in attendance remained, quote, adamantly opposed to defining any areas in which parents can make treatment decisions. Several other physicians were also reluctant to give over this power in any but the most extreme situation, end quote. Still, a majority of the medical professionals at the conference seemed to favor a genuine role for parents in treatment decisions, and some called for an entire rethinking of the models and goals of neonatology. While the Burlington Conference and Garrison's subsequent pediatric article are indicative of the fact that parents were able to garner the ear and support of some neonatologists, reform of NICUs and the implementation of the principles took another decade, and implementation remained uneven. It took until the early 21st century for many NICUs to move to new quarters that facilitated greater privacy, both of clinical discussions and for mothers to nurse their infants and parents to practice kangaroo care, skin-to-skin contact with their infants. The physical transition of clinical space coincided with a more meaningful move to family-centered care and a recognition of the distress that NICU parents experienced. By the early 2000s, NICUs began to establish psychological support services for parents, as well as formal neonatal palliative care programs. These services too, however, were unevenly distributed, since in many hospitals, the employment of support staff has been hampered by a lack of financial resources. Garrison was always careful to acknowledge the support of medical professionals. Writing the principles and the development of the pediatrics article, she told audiences after Burlington, was in itself the result of an unprecedented effort in parent-professional collaboration that lasted nearly 1.5 years and involved the input of parents, physicians, nurses, social workers, attorneys, and ethicists. But her call for Glasnost and Perestroika also reminds us of the very political nature of this fight. Echoing the assessment of several clinicians of the field of neonatology, Garrison called parents to action. Quote, there is a growing tone of sober reevaluation, a sense that neonatology has backed itself into some difficult ethical and medical corners and might benefit from informed public and parental input, end quote. Just as Peggy and Robert Stinson, John and Sue West, and Jill Lawson had made their grievances public and by doing so contributed to the emergence of a fledgling parent advocacy movement, Harrison reminded her audiences that parents needed to speak out and raise a fuss. Glasnost and Perestroika required more than mutual support and information exchange. And in her post-Burlington speeches, she offered examples of parents who had begun to take matters into their own hands. Unable to get the neonatologist at one NICU to agree to take their severely ill infant off life support, they had contacted an ethicist and neonatologist at a neighboring hospital who agreed to the transfer of the infant and the plan to withdraw life support, leading the uncooperative neonatologist to change his mind. One father had disconnected their infant from a ventilator, and a woman in preterm labor had called from the hospital where she had been admitted to find out where she might get a late abortion, and then discharged herself to get said abortion rather than put her premature infant and herself through a NICU ordeal. Indeed, there was a joke out there among clinicians that if they were pregnant, they would just go into the wilderness so that if they delivered early, they were so far from any medical care that they wouldn't be able to get any. In a country where pro-life politics led to deep political divisions in any discussion involving fetuses and newborns, parents had to be willing to stand up for their own and their premature infants' behalf. Unfortunately, as those of you who have followed the aftermath of Dobbs will be well aware, neonatology continues to be haunted by pro-life politics. And as Jackie Wolf will be the first to tell you about her daughter's experience, in some hospitals, pro-life politics still justifies withholding information from women and coercing them into aggressive treatment. And as the Alabama Supreme Court has now determined that embryos created through IVF are to be considered children, we seem far away from reproductive healthcare services that consider the lives and futures of parents alongside the desire to save every fetus. Thank you. Can you see something?
Wow. Amazing. So much to think about. And this project is off to such a great start. Really, thank you so much. Another round of applause, I really.